Hello, everyone. Welcome to this week's Health for the World Radiology Grand Rounds. Thank you for joining. We are so happy to have you here. Please feel free to introduce yourself in the chat section and tell us where you're logging in from. We will have a Q&A session after the lecture, so please add any questions you may have in the Q&A box. It's my pleasure to introduce our guest speaker for this week, Dr. Matthew Lazarus. We are so honored to have him today, and he will be giving a talk on acute aortic syndromes. Dr. Lazarus is an attending radiologist and an assistant professor of radiology at Montefiore Medical Center, Albert Einstein College of Medicine in Bronx, New York. His clinical focus has been cardiothoracic imaging, which includes diagnostic CT, lung cancer screening CT, chest radiography, as well as cardiac CT and MRI. In 2005, Dr. Lazarus received his Bachelor of Arts in Biology at Cornell University. He then attended Stony Brook University and received his Doctor of Philosophy in Neuroscience in 2011 and his Doctor of Medicine in 2013. Dr. Lazarus began his postgraduate training in 2013 with an internship at Winthrop University Hospital. His training continued at Montefiore where he completed a residency in radiology in 2018 and a fellowship in cardiothoracic imaging in 2019. Dr. Lazarus' research focuses on pulmonary embolism diagnosis and the role of the radiology in the management of the patients. His work has been published in several peer-reviewed journals and has been presented nationally. Dr. Lazarus, we're really honored to have you here today. Thank you so much for joining, and please start whenever you're ready.
All right, thank you. Thank you so much for that introduction. Okay, so today I'm going to be talking about acute aortic syndromes. Okay, I have no relevant disclosures. Okay, so acute aortic syndromes are three interrelated conditions, all involving disruption of the medial layer of the aorta. So most prominently is aortic dissection, and then also I'll talk about intramural hematoma and penetrating atherosclerotic ulcers. Okay, so presentation. The classic presentation is chest pain radiating to the back. We all know that from our training. But some other things that can cause symptoms in acute aortic syndrome is causes of end organ ischemia, so stroke, abdominal pain, or limb pain. I'll talk a little bit more about those in a bit. Or cardiac or pericardial involvement. So in a case where somebody has rupture and pericardial tamponade, the patients can actually present with hypotension. And they can also, if there's involvement of the coronary artery, signs of an MI. Okay, the epidemiology is that this has an incidence of about 3 per 100,000 per year, and is a bit more common in males than females. It's most closely associated with hypertension. Atherosclerosis can also play a role, particularly for penetrating atherosclerotic ulcers. Connective tissue diseases like Marfan's, Loeys-Dietz, and Ehlers-Danlos, as well as other conditions with congenital anomalies such as bicuspid aortic valve or coarced aorta, which are actually forms of, at least bicuspid aortic valve is a form of an aortopathy beyond just having the structural abnormality. Vasculitis, infection, or iatrogenic causes can also contribute to this condition. Okay, so this is primarily an imaging diagnosis. You may suspect an abnormality on radiograph. So if the mediastinum is widened, that can raise your suspicion, but that's a very non-specific finding, especially in older patients with vascular ectasia. Portable radiographs are notoriously bad for this. But if you have a prior and you see a change from the prior exam, that could raise your suspicion. Also, if you see displaced calcifications, that could also make you think about an aortic dissection. But really, the modality of choice is CT angiography. So for this, you want to do a pre-contrast phase, and that is to evaluate for blood, particularly an intramural hematoma or thrombosed blood. And then you want to do a post-contrast phase with aortic timing. And for this, you would use bolus tracking or timing bolus, or sometimes empiric timing, and this would depend on your institution and your equipment and the comfort level of the techs, etc. You would want to give about 75 mLs of iodinated contrast at a pretty decent rate of about 3 to 5 mLs per second, and you would want to do thin reconstructions to help evaluate all the features of a potential dissection, where the flap is, where the entry tear is, etc. ECG gating is a topic of debate. So there are advantages to doing these studies ECG gated. It has reduced motion artifact at the aortic root, and it's able to evaluate the coronary arteries. However, there are disadvantages with doing ECG gating. So there's a higher radiation dose, and it's particularly difficult in tachycardic or non-sinus rhythm patients. So this is something that would depend on, again, equipment availability and comfort level. At my institution, we typically do these studies without ECG gating, unless there is a reason to specifically suspect something at the aortic root, and that could be suspicious findings on echocardiography or initial findings on a CT that you want to further evaluate. Okay, MR angiography is also something that's available for dissection. It's useful for renal failure or young patients, but it's limited by availability, longer imaging times, and definitely lower resolution. So we occasionally will do these in patients that the clinician really doesn't want to give IV contrast to, because you can do this without contrast, and in young patients. But mostly we'll use MR angiography for monitoring a known aortic abnormality. Okay, so I'll start with talking about aortic dissection. So this is separation of the aortic wall layers with formation of false lumen along the medial layer. It's associated with hypertension as well as degenerative changes in the aortic wall. It can also be seen with connective tissue diseases, like I mentioned, Marfan's, Turner, bicuspid aortic valve. And it essentially is an intimal tear that allows blood access to the media, and then that blood forms a false lumen that extends in antegrade and or retrograde directions. And the site of intimal tear is most common at the sites of the highest strain in the aorta, which is the right lateral wall of the ascending aorta, or the proximal segment of the descending aorta. Okay. So an aortic dissection is classified with a couple different schema. So the DeBakey scheme, which is not as commonly used, but some surgeons may still use it, so it's helpful to know about it, has 3 different types. So type 1 is it begins in the ascending aorta and it extends into the descending aorta. Type 2 is it begins and stays within the ascending aorta. And type 3 is it begins in the descending aorta. In the more commonly used Stanford definition, there is not a distinction. If it begins in the ascending aorta, it's type A, and there's not a distinction based on how far it extends. And if it begins within the descending aorta, it's type B. Okay, so the usefulness of this this classification is that it directly impacts management. So typically type A, which is the most common, it's about 60% of cases, typically that is managed surgically. Type B is typically managed medically, so blood pressure control, pain control, etc. If it has complicating factors, though, that may be an indication for surgical or endovascular repair. I'll talk a little bit more about those, but that would be things like persistent pain, aneurysm formation, rupture, or end organ ischemia. So dissections that begin at the aortic arch are not really defined with either classification, so it's been suggested to call these type B with arch involvement. Often these occur from a retrograde extension from a type B dissection, and that retrograde extension does not substantially impact mortality. So these cases are medically managed initially, and that is why they should be primarily classified as type B. Okay, so here is an example of a dissection. You can see a dissection flap here in the aortic arch, and as we continue down, you see it's certainly involving the ascending aorta, so this would be a type A dissection. There's also, this is developed on the background of an aortic aneurysm, and the dissection also extends down the descending aorta. So this is a Stanford type A or a DeBakey type 1 dissection. Okay? All right, here is another case, and this is an example of a very abnormal chest radiograph. And, you know, if you see this on a chest X-ray, you certainly want to know what the explanation for this is. It could be a vascular abnormality, it could be a mass, but if it were more subtle, it would be helpful to compare it to a prior exam, and you can see that there was a dramatic change from 2013 to 2019. So on CT, you can see there's a dissection that extends up into the right subclavian and into the the left subclavian and the left common carotid. As we go down a little further, you can see there's a markedly aneurysmal aorta. And here in the ascending aorta, we see an entry tear and a very large aortic aneurysm. And then this dissection extends inferiorly. Okay. So when evaluating an aortic dissection, you want to do your best to identify the lumen. So there'll be a true lumen and a false lumen. The true lumen is typically smaller. It has outer wall calcification, and it generally has brighter enhancement. The false lumen is typically larger. It should have a beak sign, so you can imagine the inner layer of the intima of the aorta being sort of peeled away from the wall, and that gives you sort of an acute angle. And then typically the false lumen will also have less enhancement. So if we go back for a second, we'll have more examples of this. This is the false lumen here. This is the true lumen. You can see the true lumen is smaller, and you can see this acute angle that's formed within the false lumen. Just check the chat for a second. Okay, good. Okay, and then you want to know if it's complicated or uncomplicated. So uncomplicated should not have any evidence of rupture or malperfusion. Complicated will have evidence of rupture. I just want to say something about rupture. You know, if somebody has an aorta that has a frank rupture and there's blood pouring out, that person's probably not going to survive to the point of imaging. But in a lot of cases, a rupture might be better thought of as a leak or an ooze, and those are the patients where it would be possible to image and then to intervene on. So when you're looking at these cases, you want to look for a pleural or pericardial effusion, particularly if it has high attenuation, and that could be from some thrombosed blood products or from some contrast if it's on post-contrast imaging. Although best to look for these things on pre-contrast. I'll show an example of that. You also want to look for stranding around the aorta, particularly the abdominal aorta, and retroperitoneal hematoma. You want to look at the heart. Some things to consider would be extension of the dissection into the coronary artery or involvement of the aortic valve. So these patients can present with an MI if it extends into the coronary artery, or with new onset aortic valve insufficiency. You want to consider renal malperfusion. So hypoattenuation on CT would be a sign of renal malperfusion, but keep in mind also that if the supplying renal artery arises from the false lumen, it may still be perfused, but with a delay. So this could be further evaluated with delayed imaging or nuclear medicine renal scanning. Visceral malperfusion clinically would present with extreme pain, peritoneal signs, and elevated lactate. And you could look for hypoenhancement of abdominal structures on CT. Stroke or spinal cord ischemia are also potential complications of an aortic dissection. Not something you would typically see on chest imaging, but something that clinically could be deciphered or with other dedicated imaging. Okay, so you also want to comment on the branch vessels. You want to say where the dissection flap extends to. For the branch vessels, you want to say if they arise from the true or the false lumen. And you want keep in mind that the dissection can cause ischemia, but you may not necessarily see that on imaging, and that's because the obstruction of a branch vessel can be either static, if there's a flap that's sort of herniated into the branch vessel, that you might be able to see on a CT, but there can also be dynamic obstruction where the flap is moving back and forth throughout the cardiac cycle, and those can be more difficult to image. Okay, so here is an example of a type B dissection, and you can see that this is the false lumen that has an acute angle, and it's less opacified. This is an exception, though, where the true lumen is actually a little bit bigger than the false lumen at this level. And then here in the ascending aorta, this is a pitfall, which I'll talk about a little later, where there's some motion artifact, and you can see it on both sides of the aorta, and there's no flap here. This is a type B dissection with sparing of the ascending aorta. Importantly, though, if you look at the kidneys, you can see here that the lower pole of the kidney is actually less perfused than the upper pole, and that's because this patient had two renal arteries on the right, and the inferior renal artery was arising from the false lumen, whereas the superior renal artery was arising from the true lumen, and that's why this part of the kidney is ischemic. Okay, here's another example. As we come down, you can see some abnormality up here, maybe some ulcerated plaque, and here is a dissection flap and with a pretty clear entry tear in the distal aortic arch. Okay, and as we come down, you can see the false lumen here with the acute angle. The false lumen is larger. This is a good example of how you can't rely on the difference in enhancement to tell you necessarily the true or false lumen. You can see the dissection flap sort of spiraling around as we come down. And here it's actually quite compressed. This is the celiac artery, which is arising from the false lumen. As we go down a little further, you can see the dissection flap actually extends into the SMA. So this person is going to be at risk for bowel ischemia. Here is the right renal artery arising from the true lumen. And this is the origin of the left renal artery arising from the false lumen. And you can see that the left kidney is much less enhanced than the right kidney, and that's certainly something that you would want to comment on. Okay, and then you can see the dissection flap continuing to spiral around a bit. This is the IMA arising from the false lumen. And then the dissection flap actually extends into both common iliac arteries and even into both external iliac arteries, as well as the right internal iliac artery. So this was a pretty severe case of type B dissection, but again, maybe, depending on how concerned they are about the kidney, may be managed medically, actually. Okay, here is an interesting case. This is a 38-year-old male, and this, for most people, we would call this a normal chest X-ray. The only thing that's abnormal about this patient is that he has a tortuous aorta, which is very common, except it's not very common in a 38-year-old. So this person had uncontrolled hypertension, and a couple years later presented with this CAT scan after having witnessed syncopal event. And you can see that there's a pericardial effusion. But what's interesting about this pericardial effusion is that it is the same density as the blood pool. So on the post-contrast images, you can see the ascending and the descending aorta look okay. But as you come down, you start to see some hint of a flap here in the ascending aorta. And this could be motion artifact. However, usually you would want to see that in more than one place. So you would want to see an abnormality on the opposite side of the aorta. And you would also expect some more evidence of motion artifact in that area. So as we come down further, we still see this suspected flap here, and some abnormal appearance at the origin of the left main coronary artery. But again, now we're getting limited by motion artifact. And as we come down further, again, you can see this pericardial effusion. So this patient also had suspicious findings on echocardiography, and we ended up doing a gated study focused on the heart and the aortic root. And here's a maximum intensity projection of the left main coronary artery. But as we look at thinner slices in the cross section, you can see there's a little dissection flap here in the left main coronary artery. And then on a longitudinal reconstruction, you can also make it out here. So this is an example of extension of an aortic dissection into the coronary artery, but it was most evident on the initial non-gated study because of that suspicious high density pericardial effusion. Okay. All right, so I'll move on to intramural hematoma. So this is acute hemorrhage within the layers of the wall of the aorta. There should not be an identifiable communication between the true and false lumen. It may be secondary to trauma, penetrating atherosclerotic ulcer, microscopic intimal tears, or rupture of vasa vasorum. This is previously what was thought to be the primary pathologic mechanism, but this has sort of fallen out of favor, and it's thought to be more related to these other causes. And it can cause an aortic infarct, and it can progress to aortic dissection. It accounts for about 5 to 15% of acute aortic syndromes. Imaging features, you'll look for a crescent hyperdensity, and for this you need to use the pre-contrast images. And you also need to use a narrow window. So you would want to use, something like a liver window or brain window that will really bring out the subtle difference between blood in the aorta and thrombosed blood in the aortic wall. The differential diagnosis for this would be a thrombosed false lumen of an aortic dissection. So typically an IMH will have a constant relationship, circumferential relationship with the aorta, whereas a thrombosed false lumen, which basically is an aortic dissection, would be expected to spiral as you go up and down. Okay, so here's an example of this is a pre-contrast phase of an aortic dissection study, and you can see a subtle hyperdense wall thickening here. And you can see displaced intimal calcifications. And then here, as we go down a little further, you can appreciate this is a little bit more dense than the blood pool. And then on post-contrast images, you can see that this area does not enhance. And the importance of doing the pre-contrast part is there's a couple of reasons. One is that this is not such a subtle case, but if it's more subtle, you can easily miss it on the post-contrast. And then if you are able to identify some wall thickening on the post-contrast, it'd be difficult to distinguish between an intramural hematoma and a vasculitis. So if you just saw this post-contrast image, your first thought might be some form of vasculitis. But with it being a little bit hyperdense on the pre-contrast, that would point toward an intramural hematoma. Okay, some additional findings on intramural hematoma is something called an intramural blood pool. So this is localized contrast that pools associated with a branch artery from the aorta. It should have a tiny or non-identifiable communication with the true lumen, and importantly, it does not impact prognosis. This is compared to an ulcer-like projection which is a localized contrast outpouching from the true lumen. It should have a larger communication with the true lumen, about 3 millimeters or more, and it may reflect a new opening between the true lumen and a thrombosed false lumen, or IMH. And this, importantly, can progress to aortic dissection, or it can heal. So it can go either way, but generally, when these are identified, it will worsen the prognosis. Okay, so here is a published case that is really quite beautiful. It shows these intramural blood pools at multiple levels, and you can see that they're small. They collect within the hematoma. There is a small communication with the true lumen, and these are also at the sites of branch vessels. So typically lumbar arteries or the like, and there can be numerous ones. Compare that to this, where there is a focal outpouching with a wider communication with the true lumen. So this patient also has some evidence of rupture and with retroperitoneal hematoma and stranding around the aorta. But this specifically is an example of an ulcer-like projection. And then this is another published case where you can see that it's gotten quite large. There is a small communication with the true lumen, so that is something that would more typically be seen with an intramural blood pool, but we wouldn't expect it to get this large. And this also was not associated with a branch vessel. Okay, so the last component of acute aortic syndromes is this penetrating atherosclerotic ulcer. It's atherosclerotic plaque that has eroded into the medial layer. It's often associated with an intramural hematoma. So there's overlap with ulcer-like projection, and this is an example of some of these terms are not so clearly defined, and that might be a reflection of the fact that they're all interrelated, and the distinctions between some of these conditions is at times somewhat artificial. So if you look in different literature, you may find some different definitions of these things. So I've tried to sort of express that what most commonly the terms that are used. So PAU is most common in elderly patients with severe atherosclerosis. It can also occur in patients with connective tissue disorder or with mycotic plaque. Okay, it's less common than an IMH. It accounts for about 2 to 8% of acute aortic syndromes. And the complications are it can progress to an intramural hematoma or a saccular aneurysm, or aortic dissection or aortic rupture. So it certainly needs to be followed. It's often treated just with medical management and surveillance. Okay, imaging features are outpouching with jagged edges, and the differential diagnosis is an ulcerated atherosclerotic is an ulcerated plaque, which should stay within the intima. A PAU should extend beyond the expected border of the aorta, whereas an ulcerated plaque would be a plaque that extends into the lumen and then part of it has been degraded away. Okay, so here's one of our examples of this, and you can see this small outpouching here at the descending aorta, which goes a little bit beyond the expected border of the aortic wall. So the aortic wall extends out a little bit here, whereas we would expect it to be a little bit more closely associated with the true lumen. And here are some coronal reconstructions, and again, you can see this outpouching here and here. Okay, here's a more dramatic case from the literature, and you can see this outpouching, which clearly extends beyond the expected border of the aortic wall, which should be about here. And you can also appreciate that on this sagittal reconstruction. You can also see that there's extensive atherosclerosis in this patient, which is a predisposing factor for developing a penetrating ulcer. Okay, I want to talk about a new classification scheme, which is worth knowing about, but it's not really replacing the Stanford system that most of us are familiar with. The motivation for this updated classification is evolving management strategies. So the A and B dichotomy for dissection is useful because it's, everybody knows it. It aids quick communication, and it generally maps onto how they're managed. So at our institution, a type A dissection, for example, goes to CT surgery, and a type B dissection will be managed by vascular surgery. Um, However, there are evolving management strategies, and it would be useful to have uniform descriptions for research purposes as well. And like I mentioned before, there are some gaps in the existing schemes, such as when they involve the aortic arch. So this new scheme was proposed in 2020 by the Society of Vascular Surgery and Society of Thoracic Surgeons. It's a little bit overwhelming, but it actually does make sense. So I'll just talk about it for a bit. So they still talk about A and B types of dissection, but it's based on not where the dissection begins, but where the entry tear is. So if the entry tear is in the ascending aorta, which is segment 0, it's a type A. If the entry tear is not in the ascending aorta, so in segments 1 through 11, it would be a type B. If it can't be determined, it would be a type I, indeterminate, which can then subsequently be changed to A or B at surgery or if more information is acquired. So an A or an I, by definition, will involve the ascending aorta. So that would be described with just a subscript indicating the distal extent. So if you have a type A dissection that starts and begins within the ascending aorta, that would be an A0. If it starts in the ascending aorta and extends to the level of the celiac artery, it would be a type A06. It would be a type A6. You don't need to say the 0. You don't need to indicate the proximal site. And same with I. If you see a dissection that goes from 0 to 6, it would be an I6. Type B would not involve, type B, you do have to mention the proximal extent, because if you have one that develops in the descending aorta and retrograde extends back into the ascending aorta, then you would call it B0 and then give an indicator of the distal extent. So say it went down into the external iliac arteries, it would be a type B011. And if it was a more typical type B dissection that started distal to the aortic arch, say here at the beginning of the descending aorta, it would be a type B311. And I'll show an example of this in a moment. So an IMH, by this scheme, you would report the zone of involvement as well as the maximal wall thickness. A PAU, you would report the zone of involvement and the saccular dimensions. And as I mentioned, it'll be useful to be aware of this system, to have it available as a reference, but it's not intended to fully replace the existing systems. It can aid communication with subspecialists, and some surgeons may be using it in some, more so in some places. Okay, so here's the case I showed earlier. This type B dissection, you can see we can identify the entry tear here in the proximal descending aorta, or it's not in the ascending aorta, so we know right away that it's type B. And then we can see that it begins distal to the left subclavian artery. So we're going to call it 3, B3, and it extends all the way into the external iliac arteries. So this will be a type B311 by this new scheme. Okay, some pitfalls when imaging for acute aortic dissection. So causes of a false positive would be pulsation artifact. Pulsation artifact would also be a cause of a false negative. If you think that what you see is just a pulsation artifact, that can cause a false negative as well. Pericardial recesses can come up and look like a false lumen. Pericardial recesses, by the way, can also be mistaken for enlarged mediastinal lymph nodes. Beam hardening can make something look like there's a flap there when it's not really there. And to better evaluate that, you would want to see the lines from beam hardening extending beyond the structure that you're concerned about. And I would say the same advice for pulmonary embolism. Mural thrombus can be mistaken for a thrombosed false lumen. Okay, so here's a case that I showed earlier with a type B dissection, but this is just pulsation artifact in the ascending aorta. You can see, and that's because the aorta is moving throughout the imaging time, so you get sort of a ghosting artifact of it here and here. But you can see that you would see it in more than one spot. And then you can also see an example of beam hardening artifact right here. You can see this dark line here, which is not real. And you can see it also extending into the pulmonary artery on the other side. Okay, causes of false negative would be if there's inadequate contrast to pacification, and that could make you miss a dissection flap, or thrombosed false lumen, which could be mistaken for just mural thrombus. Okay, a comment about aortic grafts. So typically when a type A dissection is identified, it'll be only the ascending aorta will be repaired, and they will leave a residual type B dissection. And that interposition graft that's used to replace the ascending aorta can actually be subtle on post-contrast images. It will usually have some hyper-attenuating components on non-contrast images. So I'll show an example of that. Okay, this is an example from literature of something that initially was thought to just be pulsation artifact in the ascending aorta. But you can notice, well, you see it a little bit on the other side, but it's a little bigger here. But that will be very difficult to identify prospectively. But with gating, you can clearly see that there is an abnormality here, whether this is a PAU or a focal dissection. There's certainly something going on there. And then here's another example of how use of ECG gating helped identify extension of the flap into the aortic valve. And then there's also the example I showed earlier of on gating, we were able to see the dissection flap extending into the coronary artery. So I'm not recommending that we do dissection studies with ECG gating. I think that would cause more problems than it would solve in the long run. But it's important to be aware of the limitations of doing non-gated studies and how to deal with cases where you're still suspicious of some root involvement. Okay, and here is one of our cases. You can see a dissection flap that extends up into the left subclavian artery and also into the right brachiocephalic artery. And as we come down, we can see this dissection flap is continuing into the distal arch and down into a little bit into the ascending aorta, but also down into the descending aorta primarily. And as we come down further, someone might look at this and say, there's a dissection in the descending aorta and maybe an aneurysm in the descending aorta as well, but there's a perfectly normal ascending aorta. If you see that, you should ask more questions. Typically, you would not see a completely normal ascending aorta and a very diseased aorta otherwise. So this is actually a interposition graft for a type A dissection repair, and they left this residual dissection from the distal aspect of the graft. And then they also replaced the aortic valve. And if you look at the pre-contrast images, you can see that there is some hyperdense material at the superior aspect of the graft as well as the inferior aspect of the graft. So another way that this is a pitfall is that sometimes people will confuse these for for aortic calcifications, when in fact it's actually graft material. On a side note, after a patient has a CABG, if they were ever put on cardiopulmonary bypass, there can be some high density material that's left at the site of where the aorta was cannulated. Okay, so to summarize what I've been talking about, acute aortic syndrome is a collection of three interrelated conditions, primarily aortic dissection, but also intramural hematoma or penetrating atherosclerotic ulcer, which can both progress to dissection. You want to image this condition with both pre and post-contrast imaging. After the diagnosis is made, going forward, you don't need to do a pre-contrast. However, even after the patient has their initial surgery, or if they had any interval surgeries, it can be useful to do a pre-contrast phase for problem solving on post-contrast if you're not sure if something is extension of contrast or just surgical material. You want to evaluate for complicating features, primarily ischemia or hemorrhage. Management, if there's involvement of the ascending aorta, typically these are, which is the majority of cases, typically these are surgical and are called type A. If they're sparing of the ascending aorta, typically this is medical management, at least initially, with endovascular or surgical intervention for complicated cases. Those are type B. And just be aware of the pitfalls that I had mentioned just now. And remember that the clinical presentation of acute aortic syndrome is difficult to distinguish from cardiac disease, pulmonary disease, including PE and pneumonia, and intra-abdominal pathology. So I'll show a couple examples of aortic dissection studies. So this is a patient that had severe abdominal pain and I think chest pain, and they were suspicious for a dissection. But what the patient actually had was a big renal hematoma. The aorta itself was okay. This is an example of another patient where the patient was suspected to have aortic dissection, but what they actually had was a severe acute cholecystitis. You can see a gallstone here in the gallbladder neck, and a hydropic inflamed gallbladder. Okay, and this is a case where there was aortic dissection, but you also want to be careful of a satisfaction of search pitfall, because this patient also had pulmonary emboli. And lastly, this was another case where there was concern for aortic dissection, but the explanation for the patient's pain was actually a pneumonia. Okay, so thank you all for listening. Here's a list of references that I used. I have been checking the chat just to mostly see if there was any problems during the presentation. Okay, great. Thank you, everybody.
Thank you so much, Dr. Lazarus. It was such a very informative and comprehensive lecture. I personally learned so much. And thank you for your contribution to Health for the World. Let me check if you have any questions in the QA box. We don't have any questions.
Okay. All right. So
thank you everyone for joining, and yeah, thank you, and we are looking forward to have more sessions with you, Dr. Lazarus. It was so helpful.
Okay, great. Yes, I hope people learn from it, and please, I put my email up. I was trying to show it again, but please feel free to contact me at mlazarus@montefiore.org if you have any questions about this or other chest-related questions. Thank you.
Sure. Thank you very much for your time.